Welcome to UO Today. I'm Paul Peppis, Director of the Oregon Humanities Center. My guest today is Krystale Littlejohn, Assistant Professor of Sociology at the University of Oregon. Professor Littlejohn is an affiliated faculty member in the Global Health Program and the Indigenous Race and Ethnic Studies Program. Littlejohn's research examines race, gender, and reproduction. She's particularly interested in investigating how cultural categories shape behavior and intimate relationships and examining the consequences of those behaviors for health outcomes. Her work has been published in the Annual Review of Sex Research, the Journal of Health and Social Behavior, Social Currents, and Gender and Society, among other outlets. Professor Littlejohn's teaching interests lie in family, health, gender, race, and ethnicity, and social inequality. Her monograph, Just Get on the Pill, The Uneven Burden of Reproductive Politics, was published in 2021. Littlejohn joined the University of Oregon in 2019. Thanks, Krystale, so much for coming on the show. It's great to have you with us.
Thanks so much for having me. Great to be here.
So first, tell us a little bit about your background and how you wound up in the academy and interested in social dimensions of reproductive health and fertility.
Yeah, so I come from a very low income background, and I had no idea what it meant to be a professor, what professors did, or any of the like. And when I was in college, I obviously was fascinated by sociology, and had the good fortune of having good mentors that encouraged me to pursue graduate school and told me that I was doing really interesting work, that I had really interesting ideas. And I had just started to become interested in studying kind of the sociological dimensions of contraceptive use. And I kind of just took that as a sign that I'm fascinated by the ways that broader ideas about birth control were shaping my peers' experiences in college, and I took that and ran with it, and went straight to graduate school from college, and kind of the rest is history. I've been studying contraceptive use since then.
Okay, let's talk about your monograph, Just Get on the Pill, The Uneven Burden of Reproductive Politics. As a way of getting started on that, can you give us a sense of the book's focus and project by explaining your title?
Absolutely. So Just Get on the Pill came directly from women in the study, right? So the book is based on narratives from just over 100 women. So we interviewed 103 women that were young folks in the San Francisco Bay Area. And they were talking with us about their experiences with trying to prevent pregnancy, having sexual interactions with their partners, and really trying to navigate sexual lives as young people who are inundated with a whole host of different messages about what they should be doing. And so when we talk with them about their experiences using birth control, one of the things that I realized kept coming up in the interviews and then in the transcripts when I was doing the data analysis was women were literally saying that they were being told to just get on the pill, right? If their partners didn't want to use condoms, it's fine, just get on the pill. If their parents found out that they were having sex, we need to make sure that you just get on the pill. And so the title comes directly from learning from women about their experiences trying to prevent pregnancy and having these very gendered messages that suggested that not only was there a particular method that they should be using to prevent pregnancy, which were these prescription birth control methods designed for their bodies, but also that the message was centrally that they should be the ones doing most of the work to prevent pregnancy, if not assuming primary responsibility for preventing pregnancy. And so when it came time to title the book, I just knew that Just Get on the Pill had to be on the title, or had to be the title, because it was just such an important part of women's experiences, sharing their stories in the interviews.
So the birth control pill, introduced 61, 62 years ago, came to be viewed, and what you've told us already suggests this, as an implement for women's liberation. Mm-hmm. But you've already begun to suggest ways that your work complicates that view. Will you say a little bit about how your work complicates that understanding of birth control pill?
I think the key thing to remember with whether it's the birth control pill or other kinds of technologies is that they can be tools of liberation or they can be tools of oppression, and it really depends on how we're deploying them. And so in the case of the pill, and other highly effective prescription birth control methods like the IUD, they can absolutely be liberatory methods of birth control. They can absolutely help people lead the kind of lives that they want to live. They can help them achieve the goals that they want to achieve. But at the same time, they can also constrain their reproductive autonomy when people aren't being given the choice to use them as they'd like to use them, right? So when people are being told to just get on the pill because a partner doesn't want to wear a condom, that's not liberation, right? That's not helping them achieve the promise of the pill when they're being told that they need to use the pill so their partner can get out of using a condom, not just to prevent pregnancy, but because as part of this woman's bodily autonomy, she wants her partner to use a condom. And so one of the kind of central thrust of my book is getting us to think differently about contraceptive technologies and getting us to interrogate this assumption that these technologies are always beneficial and they're always going to positively affect people's lives, and instead to really ask ourselves, under what conditions do methods like the pill positively shape people's reproductive experiences, and how can we really work together to make sure that people are using these methods within those contexts so they don't actually experience reproductive oppression, as so many of the women in the study talked about.
So talk to us a little bit about some of the reasons that you found that the burden of birth control has fallen on the people who can get pregnant and not on the other people involved in pregnancy.
A key part of this equation was partners feeling like they didn't want to use condoms if they had a partner who was either using a form of prescription birth control or could be on a form of prescription birth control. So in the book, I talk about how partners, parents, peers, and medical providers all socialized women to believe that it was their job to prevent pregnancy and it was their job to carry the burden of preventing pregnancy, whether or not they really wanted to do that, right? So whether or not they wanted their partners to help, they were taught that they needed to make sure that they did everything they could to prevent pregnancy. So the women would talk about their mothers saying they didn't want pregnant teenage daughters, right? They would talk about partners saying, well, if you're on the pill, then the partner shouldn't have to wear a condom. They would talk about friends telling them, oh, if they're considering having a sexual interaction, then that's the time that they really need to make sure they're starting to get on prescription birth control. And so they really got these messages about using prescription birth control and assuming primary responsibility from so many different dimensions or from so many different aspects of their lives. And that's not to say anything about media. That's not to say anything about the other different sources that people could get information from. But in my work, I realized just how important the socialization experience was for teaching women that they should be preventing pregnancy using prescription birth control methods and these methods designed for their bodies, and how much the women took that to heart, right? They took those messages to heart, that in order to be good girls, right, in order to be responsible young women, they needed to make sure that they assumed primary responsibility for making sure they didn't get pregnant.
So I'm struck by the sort of breadth of sources for this argument that it's women's responsibility. You know, you said their mothers, their peers, their partners, and their doctors.
Mm-hmm.
Does your work help to explain how this view became so widespread, internalized by women as well as by the medical profession? How do you account for that? Or is that something you dealt with?
Yeah, that's something I absolutely had to grapple with even before I started writing this book. I think a key narrative in public health is that unintended pregnancy is a problem and that women, especially, are held accountable for making sure that they don't become pregnant. And I think that the message then is that in order to prevent pregnancy, women have to use the best methods to do that, right? And so there's this idea that these methods that have, after the pill came to market, right, we started having all these other methods designed for their bodies. There's the shot, there's the ring, there's the IUD, as we mentioned, or a different kind of IUD, as I've talked about before. And I think all of those messages really end up infiltrating these different areas of their lives, right? So on the part of medical providers, many of them feel really compelled to try and help their patients prevent pregnancy. On the part of parents, right, they talk about wanting what's best for their kids, and so they want to make sure they don't get pregnant. And so they end up having this message that I think is largely driven by the public health approach that says that preventing unintended pregnancy should be a central goal of women's lives. It should be a central goal for our country. And the best methods available to do that are methods designed for women's bodies. And what I really try and get us to interrogate with my work is this notion that the effectiveness of methods is itself a social product, right? That's a social consequence. So when we talk about the pill or the IUD or the shot being so effective, the idea is that those methods are so effective because women are committed to using them, right? So a woman commits to taking her pill every day. She commits to getting her shot refilled every time she has to go in to get a new shot. She commits to getting an IUD inserted. And so this idea that those methods are just the most effective methods, as if it's independent of people's commitment to using them, I think really can then obfuscate the ways that condoms can be highly effective if people commit to using those as well, right? And so when we talk about condoms being less effective, it's based on the typical use rate, which includes not consistently using condoms, right? And so the notion that they can't be effective, I think, is misleading. And if we put as much effort into making sure that couples use condoms as we do into making sure that women and people who get pregnant use their prescription birth control methods, I think that we could actually see a very different landscape than we see. But instead, the message ends up being that condoms aren't as effective, men don't like using condoms, and so the solution should be women using prescription birth control. And then they face a lot of, we could call it support, we could call it pressure to do that, right? So when if a person says they don't like a condom, we might say, well, you can just use a prescription, that the partner should just use prescription birth control. But when a woman says that she doesn't like prescription birth control, the solution isn't usually, okay, well, you just don't have to use prescription birth control, right? The solution is, well, figure out a time when you can take your pill at night. If it makes you not, if the pill makes you not feel nauseated, take the pill at night so that you don't have to deal with nausea during the day. If you don't like the pill, just keep trying different methods until you find one that you can tolerate. And so we end up seeing this really different approach to people's experiences with using prescription birth control versus using condoms. And the key thing that I really want us to grapple with is how we can change these outcomes if we change the way that we think about the methods and don't just buy into the assumptions that generally guide our beliefs about how things should go and how they have been going.
It is striking to me that you enumerate 4 or 5 different methods that women can use to prevent pregnancy, and you've named one method that men have available. Why has the medical establishment never pursued a hormonal birth control method for men? Or why doesn't that exist? Why can't I go get a prescription for birth control that I'm responsible for?
There are a number of both social and scientific factors that shape this experience, right? And so a big part of it has been issues with funding for prescription contraceptive methods, hormonal contraceptive methods for men. Part of it was that there was a market for women and it's a lucrative market for women. And so there was raising these questions about whether or not you could get men to use new methods if they were to come to market. Would that be a riskier bet since you already had a market for women that you knew existed and that you could just come up with more methods for them to use? And so some of this has been really about the political economy of coming up with new methods for men. I think some of it is, as I talk about in the book, about social thinking, right? If you don't see it as being a man's responsibility to try and prevent pregnancy, then we're going to put less effort into coming up with new ways for them to do that. And we're going to keep focusing on new ways for women to do it. And I think luckily there are methods that are undergoing, that are in development and undergoing testing, and hopefully those will eventually come to market. When they do, it will still be years into the future, but there is hope, right? That once those methods come to market, that they can start to hopefully create some change. My personal view is that we need to change our ideas about this process, right? It's not enough to just have the technology. The technology won't have the effect that we want it to have if people don't actually shift their understandings of responsibility for using contraceptives in the first place.
So let's talk a little bit more about that point, that crucial point. So tell us about some of the ideas you have to change the way people think about the responsibility for preventing pregnancy. What are some of the strategies that you talk about for making that process more equitable?
There are strategies that we can enact in schools, in families, in the medical establishment, right? There are just so many different areas that these gendered ideas about birth control have infiltrated. And I think there are a number of different ways that we can then try and create change. So in terms of one of the simplest things that I think we can do is just changing our understandings of how we talk about condoms, for example, right? So not calling the external condom the male condom and the internal condom the female condom, right? Because even that language trains people to expect that a male condom is for a man and it's out of the woman's control to be able to use, and it's not something that she should consider. So I think one part of it is language, right? One part of it is teaching all people about all available methods of birth control instead of trying to have this gendering of birth control that takes place even when people are first learning about birth control methods, right? So instead of teaching women that all they need to learn about is prescription birth control methods, right, making it clear to them that condoms are also within their right to use, that it's their right to have bodily autonomy and to have partners respect their bodily autonomy and to use condoms. And so I think some of this is making sure that at the level of learning about contraception, people have access to all of the information that they possibly can so that they can make choices about how to protect themselves from both pregnancy and disease with the best available information. A part of this is changing the ways that we cover different birth control methods, right? So kind of getting back to our conversation about the new methods of birth control and development for men, right? Thinking about the ways that we cover tubal ligation via insurance for women, but we don't have those same coverages, those same coverage protections for vasectomy for men. And so even at the kind of end of people's reproductive years, they might still choose to use tubal ligation, right? Or kind of commonly referred to sterilization, right? A woman might choose to be sterilized simply because that method is covered for her, and vasectomy wouldn't be covered for her partner. And so I think these are just a few of the different things that we can do to shift the burden for preventing pregnancy. But I think a key part of this process is we have to first recognize that something needs to change so that people can then get on board with making those changes.
So as part of your interest in these questions of equitability, you talk about the relationship or the distinction between concepts of reproductive rights on the one hand and reproductive justice on the other hand. So first of all, tell us about that distinction. What is the difference between reproductive rights approach and a reproductive justice approach? And why is that distinction an important one to make?
Absolutely. So reproductive justice is about the right to have a child, not to have a child, and to parent the children that people have. And it's a term that was coined by a group of Black women activists in the 1990s. And it really focuses our attention on the fact that people have a right to bodily autonomy and to be able to control their reproduction, but also they have a right to be able to have children and to parent those children in safe and healthy environments without fears that something's going to happen to their kids. And so one of the key things with reproductive justice is recognizing that for Black people and marginalized people, and Black women and marginalized women in particular, the courts haven't always been the safest place to get their needs met, right? And we've seen historically and contemporarily that courts have oftentimes violated the rights of the very people that they're supposed to be protecting. And so reproductive justice really emerged to recognize that the mainstream reproductive rights movement was overly focused on abortion and wasn't actually reflecting the broader needs that people of color and people in marginalized communities had. And so it arose to try and really get people to think about the importance of thinking about the spectrum of needs that people have and in grounding those needs in a rights framework, a human rights framework that really forces us to think about these experiences as a human right that is not necessarily based in the courts, right? That the courts, as I mentioned, don't always provide people with the protections that they need. And instead, we have to advocate for justice, right? So while the courts might fail to do that, as individual people and as communities, we can fight for justice so that people can eventually be able to free themselves from structures of oppression.
So we exist in a moment, as you well know, where the legal right to reproductive choice is highly likely to be significantly restricted within the next year at the federal level. Mm-hmm. Given the distinction that you just drew between justice and the law, mm-hmm. Tell us about some of the strategies that might be used to advance reproductive justice in light of the fact that it's highly likely that the law will restrict the autonomy of women and their rights in terms of reproduction.
Yeah, I think a key thing to be mindful of on this front is that reproductive justice organizations have long been doing the hard work of trying to help people have autonomous decision making when there have been restrictions after when there's been restriction after restriction aimed at limiting people's rights and aimed at limiting their ability to whether that's choose abortion or to get services for the reality that they have different reproductive needs. And so I think when it comes to the different strategies that are available right now and that people are using, right, one of the big things is trying to figure out how to support different abortion funds, right? Trying to figure out what can be done to support reproductive justice organizations on the ground who are really agitating for change. Even though we know that the courts are in charge of this decision, people really trying their best to make sure that their voices are heard and that people recognize that people in power recognize that there will be pushback, right, against the limiting of people's rights, and that people aren't just going to lie down and not vocalize, right, and not agitate for change when and if their rights are taken away. And so I think from the perspective of reproductive justice, the key is that courts have long fought to take away people's rights, and that people on the ground have long fought to try and have those rights respected. And so in my mind, even though we're entering a particularly challenging time for people's reproductive rights and for having their ability to manage their reproductive freely, in terms of from a reproductive justice perspective, the movement continues, right? The agitating continues, and the fight continues, so that people can one day, hopefully, right, be able to manage their reproductive lives freely and to have the reproductive futures that they really hope that they'll be able to have.
Are there health care policy changes that could be made that would help advance reproductive justice?
I think this is tricky in terms of in light of what's going on with the courts. I think that's going to be a tricky balance to strike. I think, as we know, the ways that some of these restrictions are really counting on extra legal mechanisms, right? So relying on neighbors to tell on people, relying on partners to tell on people, right? That's a tricky line to walk, or that's a tricky thing to get around, which I think is why it's been a particularly effective strategy that some of these people have been using. But I think in terms of the broader things that we can do, I think making sure that people have access to the contraceptive methods that they need. I think making sure that people have access to maternal health care, right? So in my mind, whether or not things change in terms of legal access to abortion doesn't change the fact that people need things right now, and that we need to keep agitating for them to be able to have those things to meet their needs. And so one thing I do want to point out is that when there are calls to restrict access to abortion, it oftentimes is kind of accompanied by these calls for people to get on prescription birth control methods. And it obviously with my work, I demonstrate that that's gendered compulsory birth control and not something that we should be doing. So even as I'm saying that, in terms of healthcare policies, we need to make it easier for people to access the methods that they need. I also want to be clear that I'm not suggesting that the solution to abortion restrictions is actually pushing contraceptive access, right? People need access to both abortion and contraception. And so in terms of our healthcare policies, what we should really be doing is trying to make sure that people have access to the full spectrum of reproductive health services that they need, so they can actually manage their experiences in the easiest and least financially difficult way possible.
So in addition to being a scholar of reproductive health and reproductive justice, you are also a teacher.
Mhm.
Would you tell us about a course that you teach or some of the courses that you teach?
Absolutely. So related to this topic, I teach a course called The Politics of Reproduction, which gets into these questions of reproductive rights and reproductive justice, and really trying to get us to think differently about the mechanisms that both enable and constrain people's ability to create families in the way that they want to create families, or to limit their reproduction when they don't want to have children. And so it's politics of reproduction is one of my favorite classes to teach. We grapple with these very sorts of questions. When I taught the last time I taught it was kind of in the thick of the very things that we've been talking about in this conversation when it comes to what legal access to abortion might look like in the near future. I also teach a course called Sex and Society, which I'm currently teaching right now, which grapples with social thinking about sexuality and sexual behavior, and really takes a sociological perspective, really takes a sociological look at things that people take for granted as being non-sociological, but that we can see if we use our sociological imagination. There's just so many different ways that we can see the ways that norms are operating, the ways that institutions shape people's experiences. And so in addition to politics, reproduction, and sex and society, I also teach a course on statistics, which is another one of my favorite courses to teach. So there, I could go on and on. I love working with students, but those are some of the key courses that I teach that also relate to the topic of our conversation today.
They sound like they must be popular courses, so timely and interesting. We're almost at the end of our time, so this will be my last question. Your book is now out. It's getting some good attention, but you have some other projects that you're working on. Tell us about one or two of the other scholarly projects that you're engaged with.
Yeah, my next big project is looking at risk perceptions among couples. So I'm in the stages of planning a project that will be another mixed method study. I'm a mixed methodologist, so doing another mixed method study that uses quantitative and qualitative methods to really start to understand how couples think about risk and how they navigate pregnancy prevention in the context of uncertainty. Right, there tends to be this assumption, I think, in both the literature, but also in the popular imagination, that probability is not part of people's experiences with preventing pregnancy, right? This idea that if people have sexual intercourse without contraception, that they're absolutely going to get pregnant every time they do that is part of the popular discourse. And I think that kids learn from a young age that that's the expectation. But in practice, right, people know that's not actually how it works out. And just like lots of other areas of our lives, people have to navigate uncertainty, and they have to think about the kinds of risks associated with pursuing particular pathways over other pathways. And so my next project is really trying to get at how people think about the risk of becoming pregnant from an act of unprotected intercourse, and how that kind of shapes the decisions that they make, and then how gender dynamics and relationship power dynamics end up being layered on top of those decisions to kind of affect the different kinds of risk calculations that people make when it comes to using various forms of contraception. So that's the big thing that's occupying most of my time outside of teaching right now, and I'm looking forward to really being able to dig into that quite soon.
Well, that project sounds fascinating, as is your book. We'll have you back when that next project is completed to tell us about that one as well. Thank you, Krystale, for speaking with us today. It's been really great having a conversation with you.
That sounds great. Thank you so much for having me. It was fantastic talking with you.
I've been speaking with Krystale Littlejohn, Assistant Professor of Sociology at the University of Oregon. Thanks so much for watching.